Hi, so this lecture is an introduction to gastrointestinal physiology. To give you an overview, um, there are really six basic processes. You have ingestion of the food, so that's selective intake of food. Then you have the secretions. Now, throughout the digestive tract, there are going to be a lot of secretions, and that's going to be to help digest. So you're gonna have enzymes being secreted, acids like in the stomach would be secreted, as well as buffers. But you're also gonna have a lot of water that's secreted. So it's a very fluid solution. And I underlined 7 liters here, not because the number seven is so exact, but more to point out that a lot of fluid gets secreted into the digestive tract. So from a clinical perspective, if somebody has, let's say, like profuse vomiting or diarrhea, you could potentially lose large amounts of volume and become dehydrated very quickly. And there are other examples of cases where you have GI inflammatory reactions and so on, where large amounts of fluid can be lost. Mixing and propulsion. So, we're going to take the contents of whatever was ingested. We want to mix it up, spread it out essentially, so that we can increase our ability to further digest, as well as to, make it come into contact with the surface of the digestive tract, so that we can ultimately absorb some of those nutrients, or put them in contact with enzymes that could help us break down the nutrients further. Propulsion, is going to be, as it sounds, moving the content through the canals, through the small intestines or large intestines and so on. And then digestion is actually the mechanical and chemical process of breaking down ingested food into smaller molecules that the surface cells can actually absorb. And so the next video lecture on the GI will actually kind of go into more about the digestive processes and some of the chemicals and compounds that are involved in that. But just to kind of give you an example now, mechanical digestion would be an example of like chewing your food. Would be the process in your stomach where you actually churn the food up. And so we'll talk about some of those examples. And chemical processes would be secretion of hydrochloric acid to activate pepsinogen into pepsin, so we can start to break down proteins into amino acids. Then there's absorption. So ultimately what we want to do is to take what was digested and then absorb it, right? So that's a way for us to get that material into either the bloodstream or into the lymphatic system, and then bring it into the appropriate places throughout our body, so to speak. And then lastly, when all's said and done, when what's not been absorbed, you would ultimately defecate that or eliminate that in the feces. So just briefly, we got to talk about anatomy when it comes to digestion, because there's so many different players that come into this. It's important to kind of understand structurally how they're arranged. So we kind of look at it as two subdivisions. You have the digestive tract and their accessory organs. So another term for the digestive tract is the alimentary canal. And so it's really essentially, you want to look at it like one long tube that goes all the way from the mouth, okay, and it's composed of like the mouth, the pharynx, esophagus. Then it leads from the esophagus as it goes through the thorax. Below the diaphragm, then you have the stomach. And then the stomach is connected to the small intestines to the large intestines or colon. And then from the colon, you have the rectum and ultimately to the anus, which essentially completes the entire the tube. And then you also have accessory organs, and the accessory organs will be, administering enzymes and signaling and doing other functions in order to aid in the digestive process, and are quite necessary to the process. So for example, teeth and tongue and salivary glands in the initial digestion phase. But then you have things like liver, which is going to contribute bile to help us absorb fats and emulsify. And then you have the gallbladder, where some of the excess bile is going to be stored. And then you have the pancreas, which I talked about in another video for metabolism. We talked about it in terms of insulin and glucagon, which are endocrine functions of the pancreas. The pancreas also has exocrine function, and so therefore it's actually going to release enzymes to help us digest the material that we ingested. And so I'll be talking more about sort of the pancreatic activity and the liver activity in the second GI lecture. To further kind of look at the anatomy here, we kind of look at the thickness of the walls in layers. And so the innermost layer is called the mucosa. And so the mucosa actually, so I'm going to circle that over here, that's the mucosa, has stratified squamous epithelium in the esophagus, for example, but it's not stratified squamous epithelium throughout the entire alimentary canal. All right, it changes. So you'd see stratified, let's say, the mouth or the esophagus, where there's a lot of like abrasiveness in the food that's being digested and so on. But as soon as we get into the stomach, that changes into things like columnar and so on. Then just below that, below the surface of the epithelium there, you'd have the lamina propria, and then the muscularis mucosa, which on this cartoon, you can kind of see the line of it here, as I drew it in red there. The muscularis mucosa is a thin layer of smooth muscle. That's a part of the mucosa. It's the last layer there in the mucosa, and it'll actually contract or relax to sort of stretch or wrinkle up or relax, if you will, smooth out the internal part of that canal, which will aid in digestion or absorption or secretion, or absorption. The next layer, once we get past the mucosa, is the submucosa, which is under the mucosa. And in the submucosa, that's where we see a lot of the larger blood vessels that are traveling through the digestive tract, our lymphatics and veins and arteries and so on, as well as a lot of our nerves. The muscularis mucosa, the muscularis externa. So the muscularis externa, right here, that's the thickness right here, from here to here. Okay. So that muscularis externa is a much thicker layer than the muscularis mucosa that I just spoke about. The muscularis externa, for the most part, is very similar throughout the entire digestive tract, where you have two layers. You have an outer longitudinal layer and an inner circular layer. And the arrangement is important for digestion, because you have to imagine that you have a bolus of food that's entered into the digestive tract there. And the longitudinal layer, if they're longitudinally arranged, when they contract, they'll actually kind of squish a column together or a cylinder together. And if the circular layers contract, that changes the diameter. All right, so it can go from open to closed. And the combination of having a change in diameter and a change in the length helps with breaking food up, as well as propulsion of the food. And then lastly, the last layer is the serosa, which is the outermost layer. Which is a connective tissue layer, which can also have nerves as well, and depending on where in the body we're talking about it, sometimes it's referred to as serosa, or even called the adventitia, which is like connective tissue that helps kind of adhere it to the surrounding organs and tissues. A couple things just to note on this cartoon is we have the diaphragm here, so we're looking really at the esophagus, right around the level of the diaphragm. We're going to talk more about the enteric nervous system in the upcoming slides, but a couple things that I just want to point out in this cartoon is that if we look at the muscularis externa for a moment, so you see the outer longitudinal layer, which is here, okay? And then you have the inner circular layer here, and in between those two layers, you can see what we refer to as the myenteric plexus. So this is a group of nerves that are all interconnected with one another. And this is, again, something you'd see throughout most of the digestive tract there, is this myenteric plexus. And one of their main functions is to cause contraction or relaxation of the muscularis externa muscles. And by the way, these muscles, through most of the digestive tract, are actually unitary smooth muscles. Unitary meaning they kind of act as like a single unit, and they kind of work together via gap junctions and so on. But there is also skeletal muscle, striated skeletal muscle, which you would actually see It's sort of in the oral and anal regions, which I'll talk about when we get there. Now, also there's the submucosal area. Again, I just want to bring your attention back to the submucosa, which is in this region here. And between the submucosa and you can see here the muscularis mucosa, you can see another plexus. All right, and that's called the submucosal plexus because of where it's located. And because of its location, it's primarily its job is actually to cause, or to innervate blood vessels that are going through there, as well as to affect secretion and absorption. Okay, this is just a slide to kind of bullet point some of the things that I just talked about, some of the things that are there. A couple things I just want to bring to your attention that I didn't mention on the previous slide is in the muscularis externa, there's thickenings of the muscularis externa, which form the sphincters. And what you'll see is throughout the digestive tract there are many sphincters that separate one part of the digestive tract from another. So, for example, you have an upper and lower esophageal sphincter that close off the esophagus both from the oropharynx region as well as from the stomach. And the stomach is separated from the small intestines by the pyloric sphincter. And the small intestines are separated from the large intestines by the ileocecal valve, which is another sphincter, and so on. Then we also have in the rectum, we have the anal sphincters. So there's sphincters throughout, and the muscularis externa is where they originate from. So it's thickenings of that layer. The serosa, as I mentioned before, it's a connective tissue. It's kind of a loose connective tissue, which is what areolar tissue is. And in some cases, it's also referred to as adventitia. And again, you'd see that as sort of like a binding property. It helps to kind of bind the pharynx and esophagus and rectum to surrounding tissues. Now, the enteric nervous system. It's actually like a subdivision of the autonomic nervous system. And so in the autonomic nervous system, that's composed of the sympathetics and parasympathetics, and the enteric nervous system is a subdivision of that. But the GI, okay, is actually influenced by both the parasympathetics and the sympathetics, which have essentially opposing effects. But if we were to say disconnect the parasympathetic and sympathetic innervation, the enteric nervous system built into the GI tract there with the myenteric plexus as well as the submucosal plexus would actually carry out a lot of the activity. So what happens is the sympathetic and parasympathetic modulate its activity. It's similar to what you see in the heart, where you could disconnect them and the heart continues to beat, but we need the sympathetic and parasympathetic to modulate its activity. So again, there's the submucosal, which is sometimes referred to as the Meissner plexus. Okay, and again, that controls glandular secretions and absorptions, which makes sense given its location in the submucosa there. And it also controls local contraction of the submucosal muscle. All right, and of course blood flow, since the submucosa has a lot of the larger blood vessels. The myenteric or Arabac plexus also has these nerve fibers that run between the longitudinal and circular muscle layers. And that helps to control something called peristalsis, which is going to help us propel digested content. And then also maintains the tone of the gut wall so that there's always a little bit of contractility, similar to how you have tone in your skeletal muscles at rest. And it also helps to regulate sphincter control. So they'll be the ones to tell it to stay tonically contracted and then relax at the appropriate time to allow digestive material to move from one segment of the digestive tract to another. So the GI nerves, so we're going to kind of break it down and talk a little bit about the general pattern of how these work. So let's start with sensory. So sensory nerves we're really talking about, or sensory neurons, we're talking about afferents. So afferents are what bring information from the GI tract to the central nervous system. Okay, and they're the ones who pick up on the sensations, and the receptors for that are mechanoreceptor. Mechanoreceptor example would be like a distension of the stomach, for example, or distension of the esophagus when there's a bolus of food there. You have chemoreceptors. The chemoreceptors respond to chemicals. Okay, like amino acids from digestion may trigger receptors. hydrochloric acid in the stomach could trigger receptors and so on. Then you have nociceptors, and nociceptors are, they're the pain receptors. So we do have, the sensation of pain in our stomach, as we're well aware. And so the afferents, I'm looking over here, are sensory neurons. We have really these three types that I've listed. We have vagal, and so the vagus nerve, if you guys recall, that's actually a parasympathetic nerve. It originates from the brainstem. Okay, and so we look over here at the cartoon. So this is the central nervous system. Okay. Now in the central nervous system, we're looking at the vagus nerve. So it's right here. So the vagus nerve, from the lecture on the autonomic nervous system, we have the efferents. So coming from the central nervous system, the efferent is this line right here, which you have a long preganglionic coming from the brainstem, and then you have a short postganglionic down here, which is typically located on the organ. So in the GI system, that postganglionic neuron would be located either in the myenteric or the submucosal plexus. The sympathetics, which we've also talked about, right? The sympathetics, here's the sympathetic over here. Actually, let me change the colors. So here's the sympathetic over here. You notice that has a short preganglionic. That's synapse in the sympathetic chain or trunk. And then from there, can then have a long postganglionic that'll then innervate the organ. And so the ganglion, where these two connect, I'm going to draw a little circle around it, that'd be the area where the ganglion is located, is either in that sympathetic chain, as I mentioned, or trunk, or something we call the prevertebral ganglia, which I have a picture of later and I'll show you. But this is just a review of how the parasympathetic and the sympathetic neurons anatomically kind of reach their organ. So again, the vagus coming from the brainstem, and then you have sympathetics coming from the spinal cord. Around the level, if we're talking about the GI, especially in the abdominal cavity, we're talking about from the level of T5 to L2. So that sort of that region of the spinal cord spans that region. And then if you guys recall, in the sacral region of the spinal cord, we also have parasympathetics as well, which are not part of the vagus. Now, in terms of the sensory coming from the GI, going back to the brainstem, the vagus nerve carries that sensory information. In fact, most of the vagus nerve that's innervating the GI, it's like a 9-to-1 ratio of sensory input going back to the brain relative to the amount of efferents coming out from the brain to the GI tract. So what you have here is, let's say down here, this is our sensation. We have distension. So that's what I wrote over here. Distension and chemicals are sensory modalities that will be picked up by the vagus in the GI tract and then sent along the vagus. So it's in the vagus nerve. It's just moving backwards towards the brainstem with its cell body located here in what's called the nodose ganglion. That's just where the cell body is located. But it ultimately it signals the brainstem. And so it signals distension, which is a mechanoreceptor, and the chemicals with the chemoreceptors. Now, you'll notice over here, the next one over here, and just to clarify, all of this right here is in one nerve. Remember, a nerve has bundles of axons in it, some going to the GI and some coming away from the GI. Now, the splanchnics. So the splanchnic nerves the splanchnic is really just referring to a lot of the abdominal cavity organs that are innervated by it. So, for example, the liver, the pancreas, the spleen, the kidneys, the small intestines, the stomach would all have sort of splanchnic innervation. And they carry pain as well as some distension and chemical as well, but they ones carry pain. There's only underlying pain here because the vagus nerve does not carry pain. Okay, just distension and chemical. The splanchnic nerves can carry pain, and so you see that down here. So here's pain, all right, and it carries that back to the spinal cord. Because what happens is it's traveling backwards along the sympathetic nerves. So it's traveling in the same nerves that the sympathetics are carried in. So I remember over here I mentioned we have the so that's our preganglionic and then the postganglionic. And then these postganglionics travel in the splanchnic nerves, but they're the efferent component to those splanchnic nerves. The pain sensation coming from the GI going to the spinal cord travel in a reverse direction via those splanchnic nerves. So it's going to pass through that same ganglia over here. So I'll just draw it out a little bit wider. It's going to pass through that same ganglia, and then as it passes straight through, its cell body is actually located in the dorsal root ganglia close to the spinal cord itself. Now, in addition, I also said it has these axon reflexes. What that really means is that in this example here, if you see pain, it sends the signal, which is going to go all the way back to the spinal cord, but it could also have a branch, which you see over here, and that branch could actually send the same signal, but it diverts, one going to the spinal cord and one going to another local structure, which could be a blood vessel or actually another group of neurons located in the GI tract somewhere else. Okay, we refer to that as an axon reflex. And then lastly here, you see the gastric ganglia, and that's really referring to the neurons located within the myenteric and submucosal plexuses. And they can create what we call short reflexes or local reflexes, which I'll elaborate on in the upcoming slides. Okay, so the efferent component, all right, you have the efferent, which is the alpha motor neurons. The alpha motor neurons, these are neurons that are innervating striated muscle. Okay, so that's actually at the beginning and the end of the GI tract, as I mentioned earlier, where you actually have striated muscle in the oropharynx. You also have striated muscle around the external anal sphincter, and so they can be, in some regards, voluntarily controlled as well, with some reflex action, which I'll talk about. But then everywhere in between is going to be smooth muscle, which is going to be innervated by sympathetic and parasympathetic. So the sympathetic, remember the prevertebral ganglia. So I want to draw your attention over here to the sympathetics. All right, let's use a different color here. So this is sympathetics. Now on the sympathetic side, you'll notice the spinal cord regions associated with that. So T1 to about L2. And then this is the sympathetic chain. Okay. And at around T5, which is what I mentioned before, to about L2 is where you're going to see sympathetic nerves originating for a lot of the abdominal organs. And so if you follow that pathway, let's just take T5 for example, it goes through the chain. It doesn't synapse there, but instead it's going to synapse at these points here. And those they're referring to as a collateral ganglia, which is another name for the prevertebral ganglia. And more specific names would be things like the celiac, superior mesenteric, inferior mesenteric ganglia. It'll synapse there. And then from there, when it synapses, the postganglionic then goes to the organ. So the liver, the kidneys, spleen, and so on. Okay? And so when it's leaving these ganglia, these prevertebrals, those nerves are often referred to as splanchnic nerves. Okay? Now, the primary idea of the sympathetics is, if you recall the lecture on the autonomic nervous system, is that the sympathetics will actually inhibit digestive processes, right? Because it's a fight or flight type of impetus that it gives. So what happens is it will decrease, motility. It'll, inhibit secretions and inhibit absorptions, and it will tighten up those sphincters so that we're not moving food throughout the digestive tract. The parasympathetics over here, remember that's a craniosacral, so we're originating from the brainstem, cranial region, and then also from the spinal cord down here in the sacral region. And the vagus nerve, all right, so actually up here, part of the digestive tract, we're talking about salivary glands and so on up here. That's going to be innervated by cranial nerves like 7, 9, and 10. But once we really get out of the oropharynx region there and into the esophagus, what you're looking at is the vagus covers basically from the esophagus and the rest of the organs, including like the stomach, for example, small intestines, large intestines, the large intestine really all the way up to the descending portion, right around this region here, the descending portion, and then that's where the vagus really stops. And then that's where you see the sacral region takes over and goes from the rest of the descending to the rest of the digestive tract from there. Its main function is the reverse to that of the sympathetic, is to increase digestion because it's a rest and digest state. So increased digestion, so which means increasing motility, increasing absorption, secretions, and so on. So what this cartoon is showing you here is that we have the myenteric plexus, which is located in that muscularis externa between the two muscle layers of the circular and longitudinal. And so that's what this is, and that controls mostly just the contraction of those muscle groups. Then you also have the submucosal plexus, which basically aids in blood vessel changing, blood vessel diameter, for example, and aids in or influences secretion and absorption. So the first thing I wanted to kind of point out is these neurons here that are part of the plexi. You'll notice that they interconnect with one another as well as between the plexuses there. So you can have the myenteric communicates with the submucosal and back and forth, and that makes sense if you want to have good coordinated digestion. You want to make sure that you're coordinating with the movement of the food as well as the digestion, so you get good feedback. So we have a lot of reflexes that are going to actually communicate from one to the other, and that would be sort of our local reflexes really, and local communication that's happening. The sympathetic and parasympathetics, which are in red here, okay, the sympathetics communicate with both plexuses, and you can see that as it kind of gives off branches in both cases. And then you can see the parasympathetics do the same thing as well, and they'll kind of modulate the activity of those two plexuses. All right, as I said before, we could disconnect them and it'll continue to function without them, but it doesn't do as good a job or as effective a job without the modulation. In green over here are some of the sensory neurons that I mentioned on a few slides ago. So they may have mechanoreceptors, chemoreceptors, nociceptors, and so on. And in some cases, it's when it's sending that signal back, it's either going to go to the brainstem via the vagus nerve, for example, or it's going to go to the spinal cord if it's following the splanchnic sympathetic pathways, and so on. So it's it can also partake in short loop reflexes as well. So instead of going back to the brainstem or the spinal cord, it may go back to the prevertebral ganglia, and then go from the prevertebral ganglia to back to the GI, which creates like a short loop there. Or in some cases, the axon reflex, which I mentioned earlier. So to kind of reiterate and kind of explain those reflexes a little bit more, we really have three types. You have the local reflex, and the local reflex, as it suggests, is located exactly on the GI tract. So it's not leaving the GI to go back to the central nervous system at all. And so that's what we're seeing over here in this cartoon. And you can see the little neurons that are located there. And they're communicating with each other, and they have their own little reflex loops. So they'll be able to respond to distension in one part of the GI tract and cause relaxation or constriction somewhere else in the GI tract. And so that can all be carried out what we call intrinsically or locally. Okay, so that's going to help things like secretion, peristalsis, mixing, and so on. Then you have short reflexes. The short reflexes just mean that they don't go all the way back to the central nervous system. So they leave the GI tract. So this example here is a short reflex. It leaves the GI tract, okay? And what you'll notice is that as it's leaving, instead of going all the way back to the CNS, it actually synapses in the ganglia there. So, for example, you may have one of the splanchnic afferents sending, let's say, a pain signal or something like that, back out off the GI. As it's traveling the splanchnic nerve, it's instead of passing through the prevertebral ganglia and going all the way to the spinal cord, it might give off a branch to the ganglia there, that prevertebral ganglia, like the celiac ganglia. And what happens is it'll send that signal directly back to the GI. So it creates this little loop here from this to the ganglia, back to the GI, and it creates what we call a short reflex. So so this way, one part of the GI tract can communicate with a more distal or more proximal portion of the GI tract at short distances away, which might be too great a distance to create an effective local reflex. And then finally, we have the long reflex. And so when it comes to the long reflex, this is the one that goes all the way back to the central nervous system. So what you have is the sensories picked up here. And so, for example, it's the vagus nerve that can send that sensation back to the brainstem. And then from the brainstem, or excuse me, it should be over here, send it back to the brainstem. And then that can go back to the GI and create a longer reflex. And in fact, if it follows the vagus pattern where it goes from a vagus afferent to the brainstem to a vagus efferent back to the GI, that's called a vagovagal reflex because the entire thing is contained within the vagus nerves. But the longer reflexes are ways in which the central nervous system can help modulate GI activity, like the smell of food, which starts the digestive process. That requires the vagus nerve, for example. That's a long reflex. And some of those long reflexes can also help communicate with even further, more distal sites of the digestive tract. Okay, so before I begin on GI motility, on the reflexes slide, which is on the previous one, I mentioned the short reflexes. So that's the one that goes from the GI tract to one of the prevertebral ganglia and then back to the GI tract. In that case, some of these specific examples, which I have listed on the bullet point there, but I just want to mention one or two of them just to give you an idea, is something called the gastroileal reflex. And basically, when there's food in the stomach, that signals from a signal from the stomach goes all the way to the ileum of the small intestine, which is the most distal part of the small intestine, and it relaxes the ileocecal valve so that the contents that are in the ileum can move out of the ileum and into the large intestine or the colon, or into the cecum. And so it helps to move food forward in response to new food coming in, essentially. You also have the gastrocolic reflex, which is when there's distension of the stomach, for example. You also get movements in the large intestine as well. And so this helps to kind of move things forward as new food is coming in to essentially make more room for the increasing ingestion. Okay, so now GI motility. I'm kind of going to go from the oropharynx and work my way downward and kind of discuss what's happening step by step. So in GI motility, you have something we've referred to as mastication, which is just chewing. So that's breaking the food down to smaller pieces. This is mechanical digestion, and it's helping the food become exposed to the saliva, which contains enzymes that can actually start chemical digestion as well, which I'll talk about later. So as part of this mechanical digestive process, the food is going to stimulate oral receptors that trigger an involuntary chewing reflex. So most people don't realize this. We can override that, of course, and do it voluntarily. But when we start to chew, we tend to not really think about it so much, and it becomes an automated sort of response. And so what happens is our tongue, our buccinator, which is really the muscles within our cheeks there, the orbicularis oris around our mouth, helps to kind of manipulate the food within the mouth so that we can kind of break it up effectively and expose it to some of the digestive enzymes as well. The masseter and temporalis elevates the lower teeth to crush the food. Okay, and so you can feel that when you're feeling your jaw and you clench your teeth. You can feel the masseter muscle, so you can feel that muscle when you're biting down. You can also feel it in the temple. So if you clench your teeth, you feel your temporalis contracting as well. And so that's going to be a crushing kind of motion. The medial and lateral pterygoids, they actually locate more inward, so you can't really palpate those. But what happens with the pterygoids is those muscles actually help to swing the teeth from side to side, and helps with a grinding motion for the food. So we have crushing and grinding, and then of course some of those muscles like the tongue help to manipulate the food and move it around. This is just the cadaver, just to kind of point out some of what I was just talking about with the temporalis. You can see that, and the masseter muscles, those are for crushing. And then what's exposed here is the medial pterygoid and the lateral pterygoid on the lower half of that. And that's going to help the jaw swing side to side and help with the grinding of the food. The pharynx. So the pharynx is really essentially it's a muscular funnel, so a striated muscle that connects the oral cavity to the esophagus. So it's funneling the food essentially into the esophagus. and it's also connected to the nasal cavity as well. And so this also connects to the larynx. So this is where the respiratory system and digestive system are sort of in close approximation with one another. So we have to make sure that when we swallow food, it doesn't enter into our trachea. So, so that's where they intersect with each other. And so these muscles, all right, they're referred to as these pharyngeal constrictors, which have superior, middle, and inferior portions to them. And what they do is they actually constrict in sort of a downward motion to help kind of force the food downward. Okay, that also helps to prevent it from coming out our nose as well. So here in this cadaver, just looking at this, the lateral aspect of this, you can see highlighted in blue, that is the nasopharynx. So let me draw that here. So the nasopharynx is this region right there. And you can see this is the hard palate right here, with some of the soft palate over here. Sorry, I just kind of scribbled it. All right, this is the septum of the nose, actually. And so here you can see that's the nasopharynx. The nasopharynx is connected just inferiorly to the oropharynx, which is, this is the tongue right here. Okay, so just behind, posterior to the tongue. And unfortunately, my video is blocking this last image here. But the last image is showing the laryngopharynx, which again would actually be, if I can draw it down here, all right, would be below into this region down here. And so that's right near the larynx. And so these muscles, again, are kind of funnel shaped, and they're forcing the bolus of food into the esophagus, which is located back here. This is the esophagus. All right, and this over here is the trachea. So this is the trachea, what you're seeing here. And so that makes this structure right there. Okay, that's the epiglottis, which is, okay, right over the glottis there, which is the opening into the trachea. So as the bolus of food gets pushed down there, the glottis should close over that, to kind of fold over the top of that to prevent food from entering into the trachea. So the esophagus is a essentially straight muscular tube that goes through the thoracic cavity, and it goes from the pharynx all the way to what we call the cardiac orifice, which is really the opening into the stomach, just below the diaphragm. And there's an upper esophageal sphincter for where the pharynx connects with the esophagus. And then there is a lower esophageal sphincter, which connects the esophagus to the stomach. So, you know, food essentially pauses at that junction where there's a constriction in the lower esophageal sphincter, and it helps to prevent contents from backing up into the esophagus. So in other words, the lower esophageal sphincter, it stays tonically contracted under normal circumstances, unless we're swallowing and something is moving into the esophagus. Then it reflexively will relax to allow it to empty into the stomach, and then it contracts again and stays tonically contracted to prevent reflux of acids going back into the esophagus. And it would tend to want to do that because the esophagus, as it goes through the thoracic cavity, is affected by the negative pressures of the thoracic cavity, and so therefore it's a low pressure system and tends to draw fluids or acids into it. So that's when we talk about like heartburn or gastroesophageal reflux disease, or GERD. That's that burning sensation people can get that's produced by acid reflux from the stomach into the esophagus. For the most part, this is information that's, you know, necessarily that you guys need to know, but it's good for anatomy. That it's non-keratinized stratified squamous epithelium, so there's a lot of abrasion going through the esophagus as that bolus of food is kind of scraping along it. But they do have a lot of mucus glands there to help secrete and help the bolus to move through. But a key anatomical characteristic of the esophagus is that the pharynx, which is striated muscle, when it connects via the upper esophageal sphincter to the esophagus, is still striated. In fact, the upper 1/3 of the esophagus is still striated. The middle, it becomes mixed of smooth and striated, and then finally the bottom 1/3 of the esophagus is smooth. And clinically this is relevant because if you have diseases that affect alpha motor neurons, and alpha motor neurons are the neurons that innervate striated muscle. That means if somebody, let's say, had a stroke or they have ALS or myasthenia gravis, for example, and these are affecting these alpha motor neurons, that means that it's affecting the pharyngeal muscles as well as part of the esophagus and can lead to something called dysphagia, where there's a difficulty in swallowing. And so oftentimes you'll see in clinics where if somebody had a stroke, you have to make sure that they're okay to swallow or take the medications orally and so on, so that they don't aspirate where they have difficulty swallowing and something gets into their trachea and they could choke or become infected and so on. So here's just the anatomy. In the cadaver, you can see this in blue. We cut away the lungs and the heart and all, so you can see that the esophagus would be descending behind or posterior to the trachea into the mediastinum there. And you can see it kind of swings towards the left, all right, over here as it goes to the diaphragm and connects with the stomach in that cardiac region there. Deglutition is actually the process of swallowing. So this is it's a complex process that involves a bunch of various muscles of the mouth, pharynx, and esophagus all working coordinatedly, and it requires a swallowing center, which is some nuclei that are found in the medulla oblongata or in the brainstem, and this helps with communication between the various muscles and the coordination of the various muscles, and that happens via the cranial nerves 9 and 10. So the glossopharyngeal nerves, right? So the tongue and the pharynx, and the vagus nerve. So the process of swallowing or deglutition starts what we call the oral phase, which is a voluntary phase, right? So as you're eating the food, you start the process of mastication. The muscles start to work the food around. You're grinding it. You're crushing the food. And then when you're ready to swallow, it becomes more of a reflexive action where the tongue actually pushes the bolus of food up against the hard palate there. So that's what you're seeing here. This green is the bolus of food. And so it's pushed it up against the hard palate, and then it slides it backwards. So the tongue pushes it back towards the pharynx and across and over, the soft palate, which you can see over here, which is the more posterior structure of the palate. The soft palate then rises as it gets pushed back, and that actually helps prevent the bolus of food from entering into the nasopharynx. At the same time, the nasopharynx will start to constrict as well as the oropharynx will constrict. And what that does is that it constricts, from top to bottom, so it pushes it downward. Will also prevent food or fluid or whatever that you're trying to swallow from coming back through your nose. And so you see the pharyngeal phase. That's the second phase, is the bolus is being pushed back. In the pharyngeal phase, you can see the palate over here. Soft palate rises. The tongue is pushed up against, flush against that, so it's not coming out of the mouth. And the pharyngeal muscles constrict so that the bolus moves in a downward direction towards the esophagus. At the same time, as that bolus of food is being pushed down, it's pushing over the epiglottis, which is located right here. And this is the trachea right here. That's the trachea, and the esophagus is back here. And so the epiglottis then covers over the trachea as the bolus of food gets pushed on top of it. Now, that's not the only mechanism for closing off the airway, because that would be actually insufficient. What happens at the same time, you have laryngeal muscles that actually pull up on the larynx, okay, which is what contains your voice box and enters as the proximal to the trachea. So what it does is you'll notice if you swallow, you'll notice that your what we refer to as the Adam's apple, so to speak, which is really just part of your larynx. As you swallow, you can feel that it actually rises. So those muscles pull upward and actually help to bring the trachea and the larynx up against the epiglottis there too. So the epiglottis comes down and the larynx comes up, and they close together. So that's when you can feel this go up when you swallow there. So that helps to close off the airway and seal that from possible aspiration. And then I put there involuntary because this is all really reflexive actions that's taking place. Despite the fact that it's striated muscle, this is an involuntary process. And then it enters in through the upper esophageal sphincter. So the upper esophageal sphincter actually has to relax at this time to allow that bolus in, because it's normally tonically constricted. And then once it enters into the esophagus, we're going to have the esophageal phase, which now we're going to enter what we call peristalsis, which is constriction, proximal. So this is constriction of the esophagus above the bolus, and then relaxation of the esophagus below it. Gravity helps out too because it goes basically straight downward, so that helps to go down. But we have to constrict above, which is basically kind of like squeezing it like a tube of toothpaste, and then dilate below it so that it has an easy path with low resistance to get through. And again, there's gonna be a lot of mucus cells there to help kind of lubricate its way through. And then when we reach the very end of the esophagus, there's going to be a reflex relaxation here of the lower esophageal sphincter, which again is usually tonically constricted to prevent acid reflux and so on. So it transiently will relax. That allows the portion of the esophagus above it to kind of push it into the stomach, and then it enters into the stomach to undergo the next process of digestion and so on. If we were to look at the junction between the esophagus and the stomach, you can actually see that here. And I just want to point this out because clinically it is relevant. Over here, what you're seeing in this region right here, okay, this is all part of the esophagus. That's all stratified squamous epithelium. And then you'll notice at this point right here, this becomes a different type of epithelium. And so that epithelium is actually gastric epithelium. So this is the junction between the esophagus and the stomach. And the epithelium is designed to be able to handle the particular conditions for which its purpose holds. So, for example, in the esophagus, it's not doing any digestion or breaking down; it's simply transporting. And so it's just abrasion resistance type epithelium. Whereas in the stomach, there's going to be a lot of acids and so on, and it needs to be able to secrete that. So there's going to be a lot more glandular activity, for example. And so its mucosa is designed differently. Now, the reason I bring this up is clinically it's relevant, this little junction here, because you have something called Barrett's esophagus. And let's say somebody has chronic reflux. That's not an entirely benign issue because if it's chronic, right, meaning it's prolonged, that acid that refluxes from the stomach back into the esophagus can actually cause metaplasia of the esophagus, meaning it changes the epithelial lining from stratified squamous into a columnar glandular type tissue so that it's protecting itself. So this is a change to adapt to this. And about 10% of that adaptive change or metaplasia can actually become cancerous. So it is something to keep in mind when we talk about reflux disease. Now, as we enter into the stomach essentially is like a muscular sac, right? And it's located in the upper left abdominal cavity, the upper left abdominal quadrant, and it's just inferior to the diaphragm, right? And it does act as like a food, a temporary food storage organ, meaning it has the capacity to really expand and hold on to a lot of food as it's able to kind of grind it up a little bit at a time and send it into the intestine. Because the last thing we want to do is take this big bolus of food. Let's say we just had, a big dinner or Thanksgiving dinner or something like that, and you had a lot of food in your stomach. The stomach is going to be able to expand in order to hold on to all that food, break it up a little bit at a time, and send that to the small intestines where most of the digestion actually takes place. We can't let that large bolus of food just enter into the intestines, okay? Because otherwise we can't really absorb or digest appropriately. So part of it, again, is it's going to be storage. And so it has the ability, although at rest, the stomach, a good portion of the stomach is actually tonically contracted. It has something called receptive relaxation. So if you eat food and that bolus of food enters into the stomach, it actually relaxes and can start to expand. And so, that helps in aiding its storage ability. Now the stomach's job is also going to be to mechanically actually churn and break up the food. And it's going to do that through what we call propulsion and retropulsion. So moving the contents forward towards the small intestine and then backwards again, back into the stomach. So we're going to see both cases. The whole job of the stomach here is really to then grind that up, liquefy it. So it's going to be secreting fluids, adding hydrochloric acid and some enzymes. And so it starts to begin really the chemical digestion portion of this, which is mostly going to be things like proteins are going to get broken down here, as well as fats. And then it's turning it into what we call chyme. And chyme is a soupy kind of pasty mixture, which is semi-digested food in the stomach. And then it's going to transfer again a little bit of that chyme at a time into the small intestine. But regardless of this activity, the digestion that takes place of the protein and fat, majority of fat and protein digestion is still going to take place in the small intestine. And then that's that picture there is just if you guys ever watch this hot dog eating contest, and these guys eat 50 or 60 hot dogs in I don't know how much time it is, but you can see one of the I guess this was a former champion here, and it's he's not pregnant, okay? So this is really just I don't know 55 or something hot dogs with their buns all stuffed in there, and it's really to show you the expansile capability of the stomach. In fact, it's been said that the stomach can actually extend from the upper left quadrant even into the pelvic cavity, holding on to the contents of food there. So the overall just kind of gross anatomy of the stomach is here. You can see the cardiac region, which is where the lower esophageal sphincter is connected, where the esophagus is coming through the diaphragm to connect with the stomach. And then you have the fundic region, which is up here. So this is the fundus, okay? And then the body, which takes up, the majority of the stomach. There's the body. And then down here, this little region down here, that's called the pyloric region, okay? Otherwise sometimes referred to as the antrum. And then down here is the sphincter. That's called the pyloric sphincter. So that's the sphincter that separates the stomach from the duodenum of the small intestine. A couple other things, you have the lesser curvature over here, and then you have the greater curvature. Okay, and in the walls of the greater curvature, located somewhere around here, I'm just going to draw a little green circle there in the wall, is actually what we call a pacemaker cell that's located in the myenteric plexus that actually keeps the stomach essentially depolarizing at regular intervals. So it has the sort of waves of contractions that occur very characteristically for the stomach. You'll notice that the muscularis externa here does not have just two layers, it actually has a third layer, so it's an exception to what I spoke about earlier. It has the longitudinal muscle, it has the circular muscle, but it also has an oblique muscle. And so you can see the oblique here, this is the oblique region here. And so effectively the alignment of all these muscles, you have kind of a scrunching activity of the longitudinal muscles, you have the constricting effect of the circular muscles, and then you have almost like a twisting effect of the oblique muscles. And so putting them all together gives you essentially like a scrunching, twisting, grinding kind of motion that the stomach can use to grind up the food that is entered into the stomach. And at the same time, it will be secreting enzymes and acids and liquefying it and turning it into chyme. The stomach, in terms of its innervation, receives parasympathetic and sympathetic innervation. And as you might guess from their function, the parasympathetic is via the vagus nerve, which can act to increase its activity and digestive ability. And sympathetic would act via the celiac ganglia, which is a prevertebral ganglia, and act to sort of inhibit or slow down the stomach digestive activity. Receptive relaxation was what I mentioned in the previous slide. It allows it to relax and hold on to a lot of food. So for example, distension can go from anywhere from about 50 mils on average, right? It can contain about 50 mils at rest, and then after a meal can expand upwards to hold on to 1,500 mils or 1.5 liters. The motility, which I've kind of alluded to a little bit already, has a rhythm, okay, of peristaltic contractions, and it has those three muscle layers. And the pacemaker cells, which I mentioned before, they keep that pace, essentially this rhythm of constriction going every 20 seconds, or about 3 times a minute. You'd get a wave of peristalsis moving essentially from the fundus downward towards the antrum, because that's the direction we want to move the food in, is from the fundus towards the pyloric sphincter, ultimately towards the small intestine. And so in doing this every 3 times every minute, it's moving that and kind of churning up the food and pushing it towards that pylorus. And what happens is, as um, as the muscle is excited to contract and it moves towards the pyloric sphincter, it actually tends to move faster than the contents inside the stomach itself. So the contents in the stomach don't move as quickly towards the pylorus as the muscle does. So the constriction actually starts to outpace the contents in the stomach. What happens is when it reaches the pylorus, it causes the pyloric sphincter to actually constrict a little bit, or constrict before the food gets there. This actually serves a purpose because what happens is the contents of the stomach then hit a closed sphincter and they bounce backwards. And when it bounces backwards, that's called retropulsion. The retropulsion, what this is, it's another way of kind of mixing then, because that bounces backwards and gets remixed and remixed. And the idea is that we want the particles in the stomach to be very small. So we don't want anything entering into the intestine to be of too large a size. So this helps to break it up. And what happens is the smaller the particles become, the more fluid-like they become, the more they can actually, the more it can get through the pyloric sphincter. The larger they are, they tend to get excluded and get retropulsed backwards and returned up until they're small enough to pass through. So again, that's the propulsion is towards the pyloric sphincter, retropulsion bounces back and gets ground up some more. And another bullet point I have there, about 3 mils of chyme is squirted into the duodenum at a time. So again, this is like a small squirt of chyme going into the duodenum at a time. It's not a big bolus. So this actually allows, first off, the duodenum to neutralize the acidic fluid that's coming from the stomach, because its enzymes do not work optimally at that low of a pH. At the same time, it also helps to the small intestines to digest the food more optimally and little by little. If the duodenum gets overfilled for some reason, it will actually send a signal backwards towards the stomach and inhibit gastric motility until it's able to handle the load that it has there actually. So there is some feedback. And a typical meal is emptied in the stomach, about 4 hours. But what is a typical meal? But 4 hours is a good sort of general estimate. Less time if there's more liquid. So if you're drinking shakes or something like that, or having fluids, that would move through much more quickly. And if you have a lot of fat content in the meal, then you're looking at longer times, like up to about 6 hours or more. So that's essentially the direction we're moving in, is away from the oropharynx, and that's the way the digestive tract is built, is to essentially move everything away from. But we can reflexively have vomiting, and vomiting would be the reverse of that, where we're actually moving or using peristalsis in a reverse direction, and where we're forcefully ejecting from the stomach some of the intestinal contents, like chyme, into the mouth and outward, right? So we have what we call in our brains an emetic center in the medulla oblongata, and that actually kind of integrates multiple muscle actions to promote vomiting. And so there are many things that can actually stimulate vomiting. Sympathetic activity can actually, an increased or overly increased sympathetic activity. So if somebody's exercising excessively, there's a lot of sympathetic output that can actually induce vomiting. Overstretched stomach, like overeating, for example, can cause vomiting. Chemical irritants like alcohol, bacterial toxins, caffeine, visceral trauma, like somebody gets punched or car accident, something like that. Any kind of intense pain, psychological and sensory actually can do it. Psychological, for example, could be having a very sensitive sort of gag reflex. When somebody hears somebody else gagging, they start to gag, that kind of thing. Vestibular stimulation, meaning that feeling of being on a boat or feeling dizzy, like the room is spinning. Going on long car rides or roller coaster rides can also stimulate that as well. And so a couple things that I have here on the right side of the slide is that keeping in mind, aspiration, which is basically some of that vomit going into the airway. Under normal conditions, what happens is the vomit gets kind of forced up. We get reverse peristalsis into the stomach. From the stomach, it goes, the pressure rises so high right? That we can actually open up the lower esophageal sphincter. The vomit can enter into the esophagus, and once it enters into the esophagus, it would stop at the upper esophageal sphincter. And in fact, the term retching refers to the fact that you have vomit all the way into the esophagus, but you still have a closed upper esophageal sphincter. And then if the upper esophageal sphincter opens, then vomiting occurs. But while that's happening, you reflexively hold your breath, and it closes off the airway so we don't aspirate. But in someone who's had a stroke, where their pharyngeal muscles are not as good, the laryngeal muscles, or somebody who's having a seizure, oftentimes I tell people with seizures, turn them on their side, right? Because they could spit up and they could vomit involuntarily while they're seizing, and you don't want them to breathe that in, causing more complications like pneumonia or some other issues. In addition, clinically, you can sometimes assess a patient just on a physical exam. I've seen this actually in psychiatric rotations that I've done, where you could have somebody who has, let's say, bulimia, for example, somebody who has a tendency to want to vomit up after a meal. And if they've done this chronically, you can actually see scars on the back of their knuckle called a Russell's sign. And at the same time, if they're vomiting frequently and chronically, that can erode the enamel of the teeth, and so that's why you're seeing some pictures of the teeth there where the teeth actually start to erode. Okay, moving on to the small intestine. So the small intestine starts from the pyloric sphincter, where we have the duodenum, which is the shortest but the initial segment, and then it goes to the jejunum, and then the ileum, and the ileum connects to the ileocecal valve, and the ileocecal valve is where the small intestine stops, and so this is actually where most of the digestive processes are going to take place. And so a lot of the enzymatic activities that take place are in my other lecture. But in terms of its motility, since that's what we were discussing, again, we have peristaltic action. So we have contraction of the small intestine. They really have a couple of functions, similar to ones we've talked about, which is to mix up the chyme with intestinal juice, bile, and pancreatic juice, because the small intestines are connected to those accessory organs I mentioned earlier. So the liver and the pancreas, for example, which contain bile and pancreatic enzymes to help aid in chemical digestion. So we're going to want to mix that up, open it up so that they can do their job, help to neutralize that acid. We also want to kind of churn up the chyme and bring it into contact with the mucosal surface. And the reason is because not only for increasing our ability to absorb effectively, but also for chemical digestion because on the surface of these cells are enzymes, and those enzymes, they're fixed on those cells. So we have to bring the chyme in contact with the surface of the intestine so that they can be digested appropriately. So we actually have two types, which again I'll elaborate more in the next lecture. But you have enzymes that are secreted into the lumen and get mixed up with the chyme and digest. And then you have surface digestion, which is called contact digestion, which helps to digest when it makes contact with the chyme on the surface of the epithelium. And then finally, to move the contents toward the large intestine. So we got to break it up, grind it up, digest it as best as we can, and then move it forward. So there's a process called segmentation. Segmentation is essentially grinding it up. The small intestines also have pacemaker cells, just like the stomach does. Their pacemaker cells fire a little bit more quickly. So for example, in the duodenum, those pacemakers go off at about 12 times per minute, the ileum about 9 times per minute, and so on. So these are fairly fixed pacemaker rates. And what they'll do is they'll contract and constrict the circular muscles at different points along the small intestine. And what they're doing is every time they constrict, they'll usually constrict over a bolus. So when the intestine, for example, gets distended, that sends a signal, a reflex action, to cause the circular muscle to constrict on it. And what that can do is that can just grind up and squishes down those boluses so that they get squished and separated from each other. And then it does it again, it separates them more, and this helps to spread out the bolus of food. All right. And then when segmentation kind of declines, peristalsis takes over, and peristalsis is the actions of actually moving or propelling that food further down the intestinal tract. So we're going to move that content forward, away from the oropharynx and towards the anal canal. So the peristalsis is different in that what it's doing is it's constricting proximally, and if this is the bolus of food, it's constricting and pushing that bolus of food down, and it's relaxing in front of it. So just like we saw with the esophagus, it's the same kind of pattern. So this cartoon is kind of showing that. So on the left-hand side, you can see on A, the segmentation, and the green is sort of the contents that are getting kind of churned up here. So initially you see these large boluses here and here, and some constrictions at these points. And then it constricts right where the boluses were, and you see it kind of separates them in different directions. And over time you start to see it spreads out in that last segment there. So that's segmentation. And then peristalsis. So peristalsis occurs in short segments. It doesn't go the entire length or the entire distance of the intestine. What it does is it'll take it, a few centimeters down. So it'll start to move that bolus further down, and then maybe it'll move it from there, another segment, and then another segment, and so on until we reach the ileum. A couple of things I want to point out is we have something called motilin, which is a hormone from the duodenum, and this is actually between meals. So if we haven't had a meal in a while, motilin levels can actually initiate something called a migrating motor complex. And these are, otherwise known as those hunger contractions. Sometimes people can feel hunger pangs. And what happens is these occur about every 90 minutes. And these are very long, sweeping type peristaltic actions where it can start in the stomach and it just sweeps slowly through the stomach, leaving the pyloric sphincter open, sweeps through the small intestine and into the colon. And the idea is it's kind of like cleaning out the lumen of the digestive tract of any particulates that have kind of stuck or got left behind. Even if they're large or small, it's a way to kind of move them all and get them into the colon and ultimately excrete them. Now, for the large intestine, we've talked about its motility. Again, that starts on the right lower quadrant there with the cecum. So there's the cecum. There's the ileocecal valve, which connects the small intestine to the large intestine. And then you have the ascending, transverse, descending. Then you have the sigmoid region, and then you have the rectum, and then finally the anal canal there. And a couple things you'll notice is that their muscular layers are a little bit different. You'll notice this over here, these little bands that you see. That's actually longitudinal muscle, which again helps to kind of collapse them. That's longitudinal muscle, so it doesn't go the entire circumference of the large intestine there. You'll also notice that you can kind of see these periodic contractions right here, these constrictions along there, which form these, what we call a haustra. And what they are is actually circular muscles located there. So here's the haustrum term. So these are really essentially large intestine segmentations. So it takes the contents that have come into the colon and it also continues to segment it and spread it out. But the colon's job, or the large intestine's job, is not really digestion at this point. It's really to reabsorb water and kind of balance electrolytes a little bit at the very end there, to help to solidify the contents to turn it into more fecal matter. And so there's gonna be a lot of water reabsorption that takes place there. And so we get segmentation, which again forms those haustra, and then we get longitudinal muscle contraction to also help to propel the contents towards the rectum. So the haustral contractions actually occur about every 30 minutes. So this is a much slower going region than we saw with the intestines. And so distension of the haustrum stimulates it to contract, and that is going to churn it up, move it around, helps us to reabsorb that water and the electrolytes that I mentioned. But then you have something called a mass movement, and these are stronger contractions that occur about 1 to 3 times a day. And so what happens is this is triggered by the gastrocolic reflex that I mentioned earlier. There's also a duodenocolic reflex, same concept, where you have distension of the stomach or distension of the duodenum triggers the colon to have a mass movement. And so what this really is just peristalsis, like large movement of peristalsis, where you can have contents move from the transverse colon, for example, all the way to the sigmoid colon in one movement. So it's basically like bulk movement, and it only happens, a few times a day. But it can be triggered again um, by distension of the stomach. And one of the classic examples of this is that you wake up after a night, right? Let's say you get 8 hours of sleep, so you get about 8 hours of fasting. You wake up and you have breakfast. You have a large breakfast, and then you notice shortly after breakfast that you have to go to the bathroom, and that reflex, that triggers, is really due to this gastrocolic, the distension of your stomach from the breakfast, causing a mass movement. Okay, and then lastly, what I want to kind of get into is just to talk about the secretions. So, for example, in the saliva, we have the salivary glands that secretes about, most of the saliva is actually water, about 99% or more is water, but it contains amylase. Amylase is the enzyme that actually starts to break down starch and carbohydrates in the mouth. Then you have lingual lipase, which is actually, it's secreted from the tongue, and it gets kind of wrapped up in the bolus of food that gets swallowed and gets triggered in the stomach to start breaking down fats in the stomach. Then lysozyme is actually an enzyme that kills bacteria, helps to keep your mouth clean, and helps to kill anything that you might have ingested. And then you have immunoglobulin A, which is an antibody that inhibits bacterial growth. So if in some conditions where people have a lot of dry mouth or autoimmune destruction of the glands that produce the saliva, they can end up with a lot of infections in their mouth, lose some of their teeth, and have cavities and so on. This is just to show you some of those glands. You can see the parotid over here, which actually has a duct that goes through the cheek tissues there, right through the muscles. And then you have the submandibular gland right here, underneath the mandible, and then you also have the sublingual gland, which is underneath the tongue. And you'll notice that the ducts to the submandibular and the sublingual, actually these open up under the tongue, and you can see that actually in the mirror. If you look at this, is the frenulum over here, so that's the frenulum of the tongue. And on either side of the frenulum is actually the opening of the submandibular. And then you have a whole bunch of smaller openings lateral to that, which are the openings to the sublingual gland. Now in the stomach we have a lot of what we call gastric pits. So if we were to look at it from the surface over here, you can actually see what looks like a whole bunch of pits. And those pits from the lateral view over here, you see it goes deep down in here and is lined by different types of epithelial cells. So on the surface, what you're really seeing is mostly mucosal cells, because the mucosal cells, they're secreting mucus with bicarb and so on to help neutralize a lot of the acidity in the stomach and to protect the lining. But as we go deeper into the pits, what you're going to see also some other types of cells that are involved in secreting acids, some that are secreting hormones like gastrin, for example, somatostatin, which I've mentioned before in previous videos, as well as chief cells that are going to release things like enzymes to help start the digestive process. So let me go. So in these gastric pits, what we have is something called oxyntic glands. All right, so the oxyntic glands. The oxyntic glands are actually primarily located in the fundus and body of the stomach. They're not so much located in the antrum. And just to remind you, the antrum is actually close to the pyloric sphincter. So the oxyntic glands are located really more proximally towards the esophagus region, so the fundus in the body there. And what they contain in their pits are mucus cells, okay, which secrete mucus, right? And parietal cells. The parietal cells, which are the cells you can see over here, which kind of look like a Nintendo 64 controller. If you guys remember those. But that's how this cartoon kind of depicts them. All right. These parietal cells, they're found mostly in the upper half of these pits here. And what they do is they actually secrete hydrochloric acid. And in addition to secreting hydrochloric acid, parietal cells also secrete something called intrinsic factor. Now, intrinsic factor is important because it absorbs, it binds to and helps the absorption of vitamin B12. And this can only occur in the stomach. So if, for example, somebody had a gastric bypass that removed a lot of their, a good portion of the stomach where their parietal cells are involved, they may not have enough intrinsic factor to absorb vitamin B12. And vitamin B12 is needed for neural tissue, red blood cell development, and so on. The chief cells, they secrete pepsinogen, which gets converted into pepsin, which is active at the very low pH of the stomach, which can again be as low as around like 3 or so, or sometimes even lower. This low pH favors the activity of pepsin, and it starts to cleave and digest proteins. There's also something called an ECL cell, or an enteroendocrine cell, and they're really concentrated lower in the glands there, in the pits, which are not depicted in the cartoon here. But these secrete hormones, usually what we call a paracrine messenger, which signals nearby cells, and that messenger is histamine. And histamine is a very key regulator of acid production by the parietal cells, which I'll show you on the next slide. The pyloric glands are located by the pyloric region, or the pyloric sphincter, in the sort of the antral region. So we're talking about the antrum now, the more distal part of the stomach. And so it has primarily what we call D cells and G cells. The G cells secrete gastrin, and the D cells secrete somatostatin. So I'll talk about their function on the next slide. But in all, the gastric juice is primarily made up of water, hydrochloric acid, and pepsin. Okay, control of gastric acid secretion. So just as I underlined at the top there, histamine is the primary inducer of hydrochloric acid release from the parietal cells. So here, what you're seeing, let me get my, all right, so what you're seeing over here is one of the pits, okay, of the stomach, and then you see the parietal cell over here. The parietal cell is the one that releases hydrochloric acid that goes into the lumen and helps us with digestion. And one of the neighboring cells here is the ECL cell. The ECL cell releases histamine. So you can see that's histamine right here. ECLs release histamine, and the histamine locally moves over and binds to the parietal cell. The parietal cell contains H2 receptors. These are histamine receptors. So it's an H2. It's a subtype of the histamine receptor. And so histamine then binds to the H2 receptors of the parietal cell and induces hydrochloric acid release. And this is actually one of the primary way in which parietal cells are triggered to release hydrochloric acid. But in addition, you know, the vagus nerve stimulates rest and digest. And so you can see the vagus nerve over here. The vagus nerve can actually directly stimulate the parietal cell, although that's actually not the main way in which it does this. It actually primarily stimulates the ECL cells, which is why you see it a little bit thicker there. It'll stimulate the ECL cells to release more histamine, which will stimulate the parietal cells to produce hydrochloric acid. And then lastly here, what you can see is the blood vessel. And via the blood vessels there, it'll release a hormone called gastrin, which I mentioned on the previous slide. And gastrin binds to receptors on both the ECL and parietal cells to induce hydrochloric acid release. It primarily binds to the ECL cell to induce histamine release, which will then induce hydrochloric acid release from the parietal cell. So again, you have the vagus nerve, gastrin, and histamine all work towards getting the parietal cell to secrete hydrochloric acid. And in doing so, they kind of potentiate each other's actions. And so clinically, we can give an H2 blocker, right, like Zantac or something like that, and that'll actually block the receptor on the parietal cell, so histamine can't bind to it, and it reduces the amount of hydrochloric acid being produced in somebody who has like reflux issues. Down here, what we're seeing now is this region here would be more in the antrum. So we're looking at the antrum. Up here was the oxyntic region, so that would be the funness in the body. But down here in the antrum towards the pyloric sphincter, what you have again is our gastric pits, and then you have the D cells and the G cells. The G cells secrete gastrin. So when digested products get into the stomach, so for example, amino acids are one of the primary triggers. So as you're breaking down proteins, the amino acids actually trigger the G cell to release gastrin into the bloodstream. The gastrin then affects the ECL cells to produce more hydrochloric acid. The vagus nerve can also directly stimulate G cells to release gastrin. In addition, the vagus nerve inhibits D cells. D cells release somatostatin, and as we've mentioned in previous videos, somatostatin has an inhibitory role. Right in the pancreas, it inhibits insulin and glucagon release. It inhibits growth hormone release in the pituitary. Here, it's inhibiting the release from the G cells. So you can see it's kind of obscured a little bit. There's an arrow down here where the D cell inhibits the G cell, so the gastrin can't potentiate the effects of acid production. And just briefly, I put over here Alexis Martin, who, this poor guy was actually shot by a musket here in the upper left quadrant, which went into his stomach and formed a fistula that stayed open, actually. So he survived this musket shot. And when it healed, it formed a fistula. And then this Dr. Beaumont actually ran experiments on the poor guy. And I mean, we learned a lot from it, but it was very unethical. And he literally actually would have poor Alexis here lay down as he would tie, like, say, meat on a string and dip it through the fistula to see how long it would take to digest. And he did it with vegetables, and he found out that, you know, meat was quicker to digest than the vegetables were. That's probably because, you know, it produced more amino acids to release more gastrin, to release more hydrochloric acid, for example. He also got to see how the muscle churns up the food and how he responds and secretes juices before giving food. So I mean, we learned a lot, but it was unethical. But it's a very interesting read if you guys are interested. The regulation of the gastric function. There's really three parts to it. There's the sort of oral cephalic, excuse me, I should say the cephalic phase, the gastric phase, and the intestinal phase. Ultimately, in the cephalic phase, there's some sort of sensory input where you see the food, you smell the food, you're thinking about food. The vagus nerve is involved in this, and so what happens is you have a vagal reflex that stimulates the production of hydrochloric acid. G cells are stimulated to secrete gastrin. The ECL cells secrete histamine, and so about 30% or so of digestion of the secretions that take place during that digestion occur right there in the cephalic phase. In the gastric phase, that's when the food is actually, the contents are in the stomach and causing mechanical and chemical digestion. So the distension causes further increases in secretions, as well as the contents. So amino acids that are being broken down stimulate the G cells and so on. That creates a lot of short reflexive loops within the stomach itself. And then finally you have the intestinal phase. Oh, and I'm sorry, the gastric phase will secrete about 60% of the secretions there. So the last 10% comes from the intestinal phase, and this is usually very transient. When some of the bolus is initially introduced into the intestine, it can actually transiently increase secretions further. However, the typical response, though, right after that transient phase, is that it goes into an inhibitory phase to slow down the contents from entering, so it can undergo the processes that I talked about earlier. Lastly, just to briefly touch on this, the stomach is protected via the mucus coat. All right, it has alkaline mucus, so it secretes bicarb that helps to neutralize the acid at the surface of the stomach. It has phospholipids and sort of a glycoprotein mixture. There's also tight junctions between the epithelial cells, so that we don't get acids leaking between the cells, damaging the underlying tissue. And then we also get rapid turnover, so epithelial cell replacement. So the cells only live really 3 to 6 days because it's a very rough environment. So there's a lot of turnover. They get sloughed off and actually enter into the chyme, and we just digest the cellular material and debris as we would any other type of material that we ingest. The breakdown of these protective measures can result in inflammation of the stomach or the stomach intestines and so on, as well as ulcerative type diseases. So things like NSAIDs, like overuse of aspirin, for example, can cause inflammation and reduction of mucus lining, which can cause acid irritation, as well as like H. pylori, a bacterium known to be able to survive in an acidic environment and cause inflammation. Okay, so the next lecture will be on the processes of actually the compounds that digest the material and how they're absorbed. Take care.